Sir worked for a few years in IMH as assistant professor. Then he started own practice in many corporate hospitals. Now he is MD and founder and MD of Asha Hospital, with first of its kind in India, and the NABH accredited psychiatric hospital, offering DNB courses in psychiatry and PDF program in child psychiatry. He has he is in private practice for past 48 years and guided more than 25 DNB dissertations. He had conducted more than 25 phase 3 and IV clinical drug trials. His areas of interest include neuropsychiatry, geriatric psychiatry, and mental health legislation. He has been the guest faculty for various CME programs and received many orations. He was a past president of IPS South Zone and vice president of ARDSI Hyderabad Deccan. He is also managing trustee of Chetana Medical and Educational Trust, which in association with the Institute of Rural Health Studies runs rural psychiatry services. He was a past president of IPS South Zone and vice president of ARDSI Hyderabad. With these few lines of introduction, I request Dr. Chandrasekhar sir to start his lecture.
Thank you, Dr. Narayan Rao, President of Telangana chapter, for the kind words spoken about me, and Dr. Manmohan Raju, Dr. Varsi, Dr. Viswasan, and all the my colleagues who have joined on this webinar. When Dr. Narayan Rao told me that let it not be a routine classroom topic to be discussed, I thought what could be the best option for me to really talk with you this evening. Majority of you, I suppose that some of the people who are listening to me are youngsters or maybe postgraduates or maybe early practitioners in their career. We learn a lot of things in our college, during academic discussions, during seminars. But how much of that knowledge which we gain in various forums we are able to really translate into clinical practice and deliver the necessary care to our patients. This is going to be the main focus of my presentation now. Can I share the screen? Sanil, can I? Where is share? But icon is not there. Share the screen.
Anil,
సార్ కింద షేర్ అని ఉంటుంది చూడండి, ఆ బటన్ నొక్కండి సార్. Yes, sir. Now go to desktop and open your presentation. Window down. Full screen, sir.
It's visible? Yeah.
yes sir.
Yeah.
Yes sir.
So what I was saying is that when we transition ourselves from an academic institute, we are left with a abundant knowledge in the specialty, but very little to do with what exactly we can do at the ground. This has been observed by me in several instances. So what do we learn in the classroom? The theoretical aspects of psychiatry, which are essential, of course, all of us should be very much knowledgeable about that. We try to understand the various tools and conceptualize the psychiatry as a specialty. For a lot of us, when our exposure to undergraduate psychiatry has been very minimal, and we have to realize that the first exposure of psychiatry where you get is equally important. Some people get their first exposure of psychiatry as an undergraduate in a mental hospital. Some people get their first exposure in a general hospital. So the concepts which you frame in your mind about the specialty are very, very crucial in the long term. Then we have various debates and discussions in our classrooms. We discuss, we debate, and we also talk about controversies in psychiatry. There are various anti-psychiatry forums even. So these controversies, we grow up with these controversies, and we do have several academic conferences. Now, all these things put some sort of a vision in our minds, like what type of practice I should do, what type of care delivery I should do. This is one thing which is probably very essential in the early years of our career. Because unless we have a roadmap ahead of us, this is what I am going to do, this is how I am going to practice, this is what I am going to deliver to the clients who come to me. This roadmap is very, very essential. Otherwise, we end up in a very in a disorganized manner in our clinical work. But real threats to learning can happen during our early formative years. This is what I'm very wary about in a lot of times. Sometimes it could be intellectual prejudices of teachers. I've known teachers nothing to any of a particular institute or particular department, but the intellectual prejudices of teachers sometimes can weigh very much on the minds of the people who listen to them, or sometimes can be influenced by them. I have known teachers who sometimes say that ECT is a worst form of treatment in psychiatry. I have known teachers who say that hospitalization is not really required. I have heard teachers who sometimes say that never work in a mental hospital. When these sort of prejudices, these are prejudiced opinions, sometimes which can weigh very much on the young minds. I think is one thing which we have to keep in mind. And sometimes dogmatic views. Sometimes we have the views expressed like uh, everything is biological in psychiatry. Don't bother about psychotherapies. They're just some sort of a pep talk. Or someone say, I'm purely a psychiatrist who believes in psychological theories only. There's nothing biological. And these are all very dogmatic views which should not be, the students should not carry this into their minds. Then we have sometimes very opinionated assumptions. Like, say, the latest is that neuromodulation is a hype sort of a treatment. It is not required. People don't respond to it. It's a placebo. So these are opinionated assumptions without any convincing scientific facts. So sometimes I have known some seniors commenting that hospitals are not required in psychiatry. Everything can be in the community. See, it all depends sometimes upon where you have received your psychiatric training. Sometimes, suppose a individual who is trained in a general hospital, who is trained in a general hospital setup, always feels that psychiatric hospitals are irrelevant or they may not be required. This is again an opinionated assumption. Way back, a few decades ago, probably some of you might be heard about the name of Dr. O. Somasundaram, a very great soul, very great person, late Dr. Somasundaram from Chennai, who worked as a superintendent of the Institute of Mental Health Chennai. Once in one of the conferences, there was a discussion about general hospital psychiatry, and one of the persons who was working in a general hospital started very vehemently arguing that in general hospitals, psychiatry, we have a lot of difficulties When a violent patient comes, we don't know what to do. I mean, general hospitals should improve and try to take care of these violent patients and blah, blah, he was talking. And very coolly, Dr. Thompson said, if you have problems, send him to the mental hospital. There are psychiatric hospitals equipped for that. So these sort of opinionated assumptions sometimes will, if such people, when they enter into the policy making bodies, that can be very counterproductive. So pseudo-intellectual discussion sometimes and verbose presentations, sometimes camouflaging the ignorance into very verbose presentations in a flowery way happens in psychiatric uh, conferences sometimes. So I think as youngsters, probably uh, one should not get carried away these things, and one should be able to put his academic knowledge to the test in a very scientific way. If I have acquired information of a particular drug or a particular therapy or a particular diagnostic category, I should be able to test it out in my own way in the practice which I do. When this sort of a scientific outlook is necessary in the early years of practice. Otherwise, we will start sometimes blindly following someone else's assumptions or someone else's presumptions, and then may not be able to do a lot of justice to our clientele. At the end of your studentship, you are awarded a degree. Now, every student gets the degree at the end of the studentship, of course, by passing an exam. Remember always that this degree gives you a license to practice, and it is not an endorsement of your expertise in the specialty. I mean, this is what that thought one should have in their mind when they're entering the practice. I have got an MD degree, but it does not endorse me to claim myself as a specialist or an expert in that specialty. At this point, you're only a certified psychiatrist who is supposed to be capable of diagnosing and treating someone with mental illness. In this context, let me also tell that most of us, after graduation MBBS, we start learning psychiatry through observing the abnormal. Nowhere in our MBBS curriculum, the normal psychology is taught, and never what the normal behavior is taught. We always take it granted. The way I behave is the normal. The way my friend behaves is normal. But what exactly is normal psychology, we are never aware. And we start our career learning the abnormalities without knowing what is normality. That is the reason why psychology is an important aspect of learning. Sociology is an important aspect of learning in the early years. Not only that, anthropology is also equally important. So the social psychology, once you ignore that, probably you will not be a complete psychiatrist later. What you learned and assimilated needs to be applied in a context where the receiver expects the best from you. It is not only the knowledge, but how I assimilate that knowledge, how I apply that knowledge at the appropriate times and appropriate situations is very much needed, and which comes through experience. Does the classrooms in our current setup train us to be a full-fledged practitioners? I'm not sure, but I don't think majority of the people who graduate can immediately be called as a full-fledged practitioners. Is there something which is never spoken or taught in the classroom which is needed for you to successfully translate your knowledge into adequate patient care? So ultimately, what's the purpose of the knowledge unless if I am not able to translate into a patient care? And that is the main issue which we have to think of. There is a significant gap between the structured textbook knowledge taught in the classrooms and the messy, nuanced reality of clinical psychiatric practice. While classrooms provide the foundational science and diagnostic frameworks, the clinic is where you learn to manage the human and ethical complexities that don't fit into syllabus. No one tells you what is ethical, what is moral way of practice. No one tells you this, your own, how you develop that. And let us also remember that psychiatry is just an empirical science. Your diagnosis and treatment are empirical. There is nothing like, in my opinion, someone who always does the right diagnosis and right treatment. We always go with some empirical guidelines. Possibly this is the diagnosis, probably this is the treatment, and then we try to look into it. There's the reason I feel that every time you prescribe or I prescribe, it is something like a clinical trial. Probably I would have seen thousands of persons suffering from schizophrenia. But still, a first episode of psychosis comes to me. I still try to understand basically which drug to prescribe. What is that which tells me this drug is going to be effective, that drug is not going to be effective? It is an empirical thing. I mean, all of us have the same amount of knowledge, but how we utilize it, assimilate it, and get the result out of it is the tactic. So the greater number of cases you see and treat more, your understanding of the specialty and the patient and the socio-cultural milieu will improve. I may have worked in a great institute and I see 2 cases in a week. I have been working in a very mediocre institute, seeing 10 cases a day. I would always value this person who is working in a mediocre institute, seeing 10 cases, than someone who sees 2 cases. Because the specialty is like that. No one can say that case A is the same as case B. So, what are the difference between the classroom and clinic? Fixed topics versus unpredictable cases. In classrooms or the case presentations, we get very typical cases, try to present them and try to discuss the management. But when you're in the clinic, you get haphazard symptoms, unpredictable sort of presentations, requiring practitioners to handle the real world challenges as they arise. The patients will not come and say, I have this problem. You have to extract the information sometimes. There is a lot of cultural biases. There are a lot of pressures from the relatives when they come to you in a group to the clinic. Idealizing patients versus comorbid realities. This comorbidity not only with other psychiatric conditions, comorbidity with various physical disorders. Say, I do remember that decades ago when we were young practitioners, we never used to bother so much of physical comorbidity. I don't know this. Health, probably lifestyle changes, new physical or maladies have started more. Very rarely, I mean, people may think it's a big joke. Very rarely, even we used to get an ECG done before the ECT. Now we are in a phase when we don't give an ECT without a CT scan of the brain and all the other investigations. So there is a lot of physical comorbidities which start occurring, and one has to really have a look at it and multiple conditions at once, which complicates the treatment. And these sort of things are not really taught in the classrooms. Diagnostic frameworks versus clinical judgment. DSM, ICD, we have diagnostic criteria. We try to give a lot of importance in our academic curriculum. But in the clinic, we don't see the symptoms exactly matching any particular diagnostic sort of a disorder. They don't align with most of these categories. And most of us rely on holistic judgment rather than just a checklist. Sometimes I may think that the person is having schizophrenia, and you ask me, tell me the DSM criteria, why you are saying this person is schizophrenic. I may not have even a couple of diagnostic criteria according to DSM, but still, my experience tells that this person is suffering. And we have to give sometimes some validity to this sort of observations. The flow chart versus relationship building. Classroom learning might emphasize a flow chart based thinking where you arrive at a particular single sort of a point and say this is the answer. It doesn't happen in clinics that way. So your other skills like empathy, teamwork, building rapport, which are difficult to master without hands-on experience. No classroom will tell you how to establish a therapeutic alliance with the patient. No classroom will tell you how to really empathize with the patient. This is what you have to acquire over a period of time. Biological theory versus social barriers. So we try to focus on neurobiology, neurochemistry, and psychopharmacology, saying that this is what explains your problem. But in the real world, patients are not going to accept that. You have to take into account a lot of their beliefs, the way they look at the illness, the way they understand the illness. Sometimes I feel that when the family says it is because of some sort of a black magic, this person is suffering, there is no point in trying to contradict and saying, no, there is a neurochemistry, there's a neurochemical imbalance that is causing the problem. What best I would probably say is, yes, whatever it is, the individual is suffering. Let us see how I can relieve this suffering to the individual. Later we can go into the causes rather than challenging them. I mean, this sort of a thing should be avoided in the first instance during practice. So, clinical practice is basically a white canvas. That is what I was mentioning. What you have, the roadmap in your mind is very, very crucial. There are several dimensions into clinical practice. No one can tell you, you go this path, you'll be successful. No. But each practitioner can charter his own course. He's influenced with various developments in the discipline. It could be the scientific developments, it could be the various shifts, social, cultural, institutional, scientific shifts will affect the professional practice. The area from which you are coming from, the cultural moorings of that environment, the institutional practices, some communities, they believe that probably we don't require this particular type of care. And of course, there are some time back you learned that the commonest example is years ago, decades ago, aversion therapy is one of the best therapies for substance abuse. That was thing used to be practiced when I was a student. Now, if you say aversion therapy, people are going to really laugh at you or discredit you. There is nothing like aversion therapy nowadays. So there are a lot of scientific shifts which will influence your professional practice. And what one should be able to look into those scientific shifts. In the present and future, we can anticipate great change, creating opportunities as well as challenges in practice. And what are that we'll see now. What are the various care delivery models which a rank practitioner should look into? One is the individual office independent practice model. How does it really look at this point of time in the psychiatric practice? This was the main mode of practice till few decades ago, till probably 10 years, 15 years ago. Majority of the practitioners used to have their own office either at home or outside and try to practice mainly a office-based practice. But the various advancements in psychiatric care has evolved that a single practitioner cannot cater to all the type of care which the individual requires. And so what you do is you don't apply those things, though you have learned that. because of the paucity of the staff, because of the paucity of time, because you are all alone and you can't do justice to the patient. It is just basically a single independent practice model can help you to start your practice, but it may not take you very far in achieving what you want to achieve. I have learned so many things, so many techniques in my institute or in my college, but very handful of them I can practice in an independent individual office type of model. Then there are private systems of care, single specialty hospitals, which are sometimes proprietary, where the individual can employ a lot of staff and see his whatever the models of care which he wanted, he can implement. Or sometimes it can be a group practice where few professionals belonging to the same discipline join together and try to see what best care can be delivered. Someone can be very good at psychological techniques. Someone can be very good at psychopharmacological techniques. Someone can be very good at different modalities of treatment. So that is what can be offered under a single umbrella. Otherwise, what happens as a in an office independent practice model is I sit, the patient requires a psychological therapy or psychological testing, go to XYZ, get the report. Then I feel that the person requires some sort of a rehabilitation. Okay, I don't have facility in rehabilitation. Go to particular center, they will do. Or the person needs speech therapy or some other occupational therapy. Okay, go to this place, they will do it. So what happens at that time is you don't have the control on your client and you don't know what is happening to your client. You are knowledgeable in what are the things needed by the client, but you are not able to apply that to that person. So this is another problem. So sometimes the private systems of care where multiple group practices occur may offer a better type of care to the patient. Then you have multi-specialty hospitals where psychiatry is one wing. And again, here we may not be able to do justice to all types of care which the individual suffering from mental illness requires. Of course, you have public health services, various government hospitals, and academic institutions. If, as an young practitioner, young graduate, one wants to do the academic work, it is better he chooses at the early time of his career and go in that direction. So I don't delve more into that. Whatever it is, we operate in a grinding social, financial, political, technological, and scientific pressures. Every practitioner, every hospital, everywhere, we have to be that grind. It can be social pressures. Your family says, no, you are spending 14 hours a day in the clinic. Or your relatives say you are not meeting us. So there's a lot of social pressure when you put more effort. Or it could be financial. You have put in a lot of money, but you're not getting the returns. It can be sometimes even political pressures in an area where you are operating. And technological, that I will come to in a little bit of time. And scientific pressures. So advances are happening so fast that you are not able to keep pace with them. So you want to learn more. Whatever it is, in spite of all these systems of care and practices that optimize core values like accessibility, affordability, accountability, and affability are likely to succeed better than that means if I start whatever, it could be a clinic, it could be a hospital, it could be any sort of a healthcare facility, any model which you adopt, it should be accessible. I can't keep my clinic or hospital in a remote place and say no patients are coming. It should be accessible. It should be affordable. Once I become unaffordable, people won't come to me. Accountable for whatever money, it could be 10 rupees or it could be 1,000 rupees. if I have taken, I should see that my client gets the value for his money. We have to provide that. Then only the trust improves. And affability, that means what the patient expected, I could deliver. The care what the patient expected, I could deliver. If you keep all this is what we call it as the 4 A's of any institution, are able to do that, probably one can establish a better model of care. Nowadays, individual patients are becoming more informed and selective consumers. This is the technological advances which we are witnessing. Contemporary media, internet, direct to consumer advertising by pharmaceutical companies and healthcare systems have educated the general public's demands. Probably when I started the practice, I didn't know what Google was, what was there, what is the review. Now, most people routinely search health information online. Patients routinely Google disorders, treatments, and clinicians. So we run into a rat race. What does the Google say that I'm a, or rate, or people rate me as a best psychiatrist or not? So expect that most of your patients will have Googled you to learn about your background and performance. So the additional pressure on you to match that. See, most of the clientele who come to you have sometimes very wrong expectations. They think that psychiatrist should spend about half an hour with every patient. Psychiatrist should see me for 1 hour every consultation, which we know, all of us know that it's not done on a day-to-day basis. It is not done, which is not required even in a lot of critical situations. Another important model of care is the disorder-focused models of care, which are coming into prominence now. And most of the youngsters should be aware of that. So, as I said, a single psychiatrist with the current level of knowledge and therapeutic armamentarium will not be capable of handling all the types of cases which come to him. So basically, each individual should try to diversify and adopt a sort of a disorder focused model where you can get expertise in that. This is not a specific models. It could be like I can be uh, an expert in, say, dementia care. I can be expert in a bipolar disorder care. I can be expert in schizophrenia care. So that whatever the schizophrenic patients requires, those skills I will harness, I will provide, and I will see to that the patient gets those treatment modalities for him. For example, a lot of times our routine practice in schizophrenia prescribe a list of drugs, say, how are you? You are hearing voices, not hearing voices. So the treatment is successful. We all know from our academic inputs that is not the end of the road for schizophrenia. There are symptoms which needs more better attention, or symptoms where other modalities like cognitive remediation techniques are required. There are so many other things. There are ECTs required, there are neuromodulation techniques required. So you have to look into these disorder focused models of care. If you are an youngster, I think we have to, it's the time now where you have to think in that direction. It could be even whatever it is. Select one area of the psychiatry which appeals to you, which appeals to you. See, unless in psychiatry, one difference is that unless you have a passion for that discipline, it's difficult to really tolerate the frustration tolerance. I hope I'm clear. See, our specialty is one thing where there's a lot of frustration. Things don't happen the way we want to happen. So you should have the frustration tolerance. And to have the frustration tolerance, you should be passionate about your specialty. If you say that my patients are not improving and they say useless, it's okay, let me prescribe, and that's the end of the day, that sort of an attitude is not going to lead us anywhere. Now, telephone and web-based monitoring and intervention programs for depression and anxiety, these are the things. Measurement-based disease management programs will progress or even chronically with psychiatric patients increasingly use computer-based tools to tell you how they are feeling. So how you introduce technology into clinical practice is also gaining some importance. Another important issue is as scope of practice expands, paraprofessionals will occupy the space in clinical practice. We already witnessed that a lot of clinical psychologists or psychologists come into the space, including probably care managers, though it is not occurring right now, probably gradually it will happen in the next few years. So that is the reason, see, even now, according to Mental Health Care Act, when there is a mental health professional, even a trained nurse is a mental health professional. Tomorrow, nothing prevents them saying that I'm a mental health professional, I'm capable of making basic diagnosis and basic treatments. Competition with these paraprofessionals will increase the functions currently performed by psychiatrists. So, what are the psychiatrists going to do? And add to this the current inclination of the government to integrate alternative medical systems in mainstream medical care. So, we have voice systems, we have various other systems which also come into the medical care systems, and we have to see how we can either integrate with them or how we can offer better care than them so that you retain your clientele. So, psychiatry utilizing other mental health professionals may see psychiatrists increasingly undertaking additional subspecialty training to remain one step ahead as routine aspects of care are increasingly assumed by paraprofessionals. This is where I always tell my colleagues and also my younger professionals, don't build too much on various psychological techniques of therapies. It is essential, I do agree, but don't deviate from your core psychiatry where we deal with serious mental disorders. The soft psychiatry, I call it a soft psychiatry, adjustment disorders, marital disputes, and some sort of a minor anxieties, panics, that may be dealt with even a psychologist or a social worker, or sometimes even a faith healer. The core psychiatry is your bread and butter. The serious mental disorders, bipolar disorders, schizophrenia, substance abuse disorders. If you are not able to take care of them, no one else will be able to take care of them. So focus on disease-specific models in those sort of a categories. In serious mental disorders, then you'll gain more confidence, more importance in your specialty. So sometimes other model nowadays, which a lot of people are doing, is home visit model. I don't have a clinic, I have a number, I take the call, I do a home visit, I prescribe, and that is the end of it. That is one type of model sometimes which can be adopted in people who are wary of. Another thing which I possibly I would like to mention is that people who would like to have a hospital-based model, I don't think you should be scared of MSCA or anything like that. There is nothing to be worried about. Just because there is a Motor Vehicles Act, we don't stop, because we don't know anything about that, we don't stop driving. So don't worry about the mental health legislation. As long as the way you're practicing is genuine, I don't think any MSA is going to be harmful. Another thing which is remote consultations and treatment using telephone, video call, Gmail. So it is something like the work from home models where all your practice is online. And again, as I said, these online consultations can be usually be offered for soft psychiatric disorders, not for the strict psychiatric disorders. So using telemedicine, primary care physicians can be guided, all these things. I think I'm running out of time. I will just try to close in. And clinical research in private practice, I am not a very good advocate of that. If you're a private practitioner, stick to your thing. Research is the domain of an institute. Let them do it. Don't mix too many things about research in private practice. It will lead you sometimes away from what you want to do. It is important. It is important. Yes, some of my colleagues will be doing in their institutes, but not me in private practice. No, but pharmaceutical and medical companies nowadays approach you because it is easier rather than going to an academic institute. The employer say that do this clinical trial for me, do this for me because it's easier in a thing. Let just skip. New years of psychiatric specialization come, child psychiatry, geriatric psychiatry, computer-based informatics, then basically neuromodulations. Even now, new imaging techniques have come wherein you can stimulate the particular neuromodulation techniques using brain localization techniques, neuronavigation techniques. So these are certain areas which people can explore. So psychiatric diagnostic and interventional neuroimaging can come in the future. Careers combining clinical practice with administration is another area, another model which one can adopt. However, whatever the advancements at this juncture, in the foreseeable future, at least psychiatrists will still be expected to master all the usual subjects near and dear to the hearts of the professionals, like broad biopsychosocial medical knowledge, clinical skills, professionalism, communication, and systems-based competencies. Irrespective of whatever is happening around the world, ultimately these are the core things which a clinician requires. And all these things are not taught in the classroom alone, which you have to acquire as you practice. And you are a student lifelong. You have to continue to keep that in mind. I didn't become an expert overnight after getting a degree. So you have to struggle to keep up that knowledge on pace with what you are seeing on the ground. And then that will make you a very good practitioner. Thank you.
Thank you, sir, for your time. Any questions you can ask? No questions, sir. So, Manmohan, sir.
Sir, thank you very much, Dr. Chandrasekhar, sir, for a wonderful presentation. Okay, 2 points నేను యాడ్ చేద్దాం అనుకుంటున్నాను సార్ విత్ పర్మిషన్ ఆఫ్ ప్రెసిడెంట్. ఈ ప్రైవేట్ ప్రాక్టీస్ లో ఇండివిజువల్ రోల్ మోడల్స్ ఆఫ్ ప్రాక్టీస్ లో ఇండివిజువల్ ప్రాక్టీస్ విత్ ఆఫీస్ టెక్నిక్ అనేది చాలా మంది డిస్ట్రిక్ట్ హెడ్ క్వార్టర్స్ లో మేము అదే చేస్తుంటాము. ఇన్ దట్ దెర్ ఆర్ ప్రోస్ అండ్ కాన్స్. దెర్ ఆర్ మెనీ ప్రోస్. ఏంటి అంటే ఇట్ బికమ్స్ లైక్ ఏ ఒక పర్సనాలిటీ డెవలప్మెంట్ కు మనకు పర్సనల్ ఇండివిజువల్ ప్రాక్టీస్ ఎక్కువ ఉపయోగపడుతుంది సార్. ఎవ్రీ కేస్ ఈస్ యూ హ్యావ్ టు డీల్ ఇండివిజువల్లీ. అది మంచిదా చెడ్డదా లీగల్ ఆర్ ఎథికల్ ఎవ్రీ కేసుకు మనం ఎక్స్పోజ్ అయి ఉంటాము. ఏ విధమైన బ్యాక్గ్రౌండ్ సపోర్ట్ ఉండదు. దానివల్ల ఏంటి అంటే మనకు లాట్ ఆఫ్ ఎక్స్పీరియన్స్, మనకు ఒక 10 ఏళ్లలో 20 ఏళ్ళ 30 ఏళ్ళ సంబంధించిన ఎక్స్పీరియన్స్ వస్తుంది. రెండోది డీలింగ్ విత్ పేషెంట్ అటెండెన్స్ ఈజ్ మోర్ ఇంపార్టెంట్ దెన్ పేషెంట్ సమ్ టైమ్స్. మోస్ట్ ఆఫ్ ది టైమ్స్ అటెండెన్స్ ఏ విధంగా హ్యాండిల్ చేస్తున్నాము, సైకో సోషల్ ఆస్పెక్ట్స్, ఫ్యామిలీ ఇష్యూస్ ఏ విధంగా హ్యాండిల్ చేస్తున్నాము అనేది చెప్పాలి అంటే మనం మీరు చెప్పినట్టుగా స్ట్రిక్ట్ గా బయోలాజికల్ సైకియాట్రీకి మన పరిధి వరకు మనం లిమిట్ చేసుకుని ఉంటే ఆ ఇష్యూస్ లోపల మనము సైంటిఫిక్ గా ఉండగలుగుతాం. ఈ పాయింట్ నాకు చెప్పాలనిపించింది. ఇది నేను 18 years ఆఫ్ ప్రాక్టీస్. దిస్ ఇస్ మై 19th year సార్. సో డిస్ట్రిక్ట్ హెడ్ క్వార్టర్స్ లో వచ్చే వాళ్ళు ఇప్పుడు ఉన్న ఆడియన్స్ లోపల ఉంటే ఎంపతి ఈజ్ వెరీ ఇంపార్టెంట్. ఎందుకంటే పేషెంట్ మన స్థాయి థింకింగ్ ఉండదు. వాళ్ళ స్థాయికి మనం కిందికి రావాలి, వాళ్ళని అర్థం చేసుకోవాలి, వాళ్ళకి కావాల్సిన డిస్కౌంట్ ఇవ్వాలి. అంటే వాళ్ళ లెవెల్కి వచ్చి ఉండగలిగితేనే మనం వాళ్ళకి ఎక్కువ ప్రేమ ఆప్యాయత తోటి వాళ్ళని హ్యాండిల్ చేయగలుగుతాం రాదర్ దెన్ బయాలజికల్ సైకియాట్రీ నాలెడ్జ్. అది నా పర్సనల్ ఎక్స్పీరియన్స్. సార్ చెప్పిన పాయింట్స్ లోపల కొన్ని వండర్ఫుల్ పాయింట్స్. ఒకటి ఇంపార్టెంట్ ఏంటి అంటే పర్సనల్ ప్రైవేట్ ప్రాక్టీస్ ఇండివిజువల్ ఉండడం వల్ల గ్రోత్ మాత్రం లిమిట్ అవుతుంది అనేది కరెక్ట్ పాయింట్ సార్. ఒక లెవెల్ వచ్చిన తర్వాత అంటే మనం టీచర్స్ నుంచి ఇన్స్టిట్యూట్స్ నుంచి నేర్చుకునే ఒక బెనిఫిట్ అనేది కొంత తగ్గిపోతుంది. ఎక్స్పాండ్ చేయడానికి అదర్ డొమైన్స్ లోకి వెళ్ళడానికి మనకు కొంత ఇబ్బంది అయితే ఉంటుంది. ఈ 2 పాయింట్స్ నేను చంద్రశేఖర్ సార్ అండ్ ప్రెసిడెంట్ సార్ తో షేర్ చేసుకుందాం అనుకున్నాను. థ్యాంక్ యూ వెరీ మచ్. ఇంకా ఏదైనా క్వశ్చన్స్ పవన్ కులకర్ణి సార్ యాడ్ అయ్యాడు, పవన్ సార్ యాడ్ అయ్యారు. సార్ చెప్పండి సార్.
Hello, am I audible, sir?
Yeah.
Sir,
పవన్.
yes. Thank you, sir. Thank you for the excellent insights, sir. My question is, sir, nowadays, there are many super specializations and subspecializations are coming up in psychiatry, sir. And I hope many postgraduates are here, sir. Sir, there are some psychiatrists who advocate against these super specialization or subspecializations also. So, what is your take, sir? Is it good that you sector yourself to a particular area of?
Yeah. See, as far as psychiatry is concerned, I think super specialization is probably required in only 2 areas. One is child psychiatry, is the one thing where you have need to have some super specialization. Otherwise, in your 3-year or 4-year of specialization in psychiatry, you will be capable of learning almost all the aspects of psychiatry. So only thing which probably most of us cannot master is child psychiatry, which needs a separate sort of a training. Otherwise, most of the other things or routine sort of a thing, I think, especially I am against addiction psychiatry as a super specialty, because any psychiatrist is capable of handling the substance abuse disorders. And the treatment modalities we are well aware of. So in that sense, probably we are going too much unnecessarily into subspecialization or super specialization in psychiatry. That is my take. Except child psychiatry, I don't think anything else is required.
One anonymous question, sir. How to tackle RMPs in initial days of practice?
RMPs, you have to accept them as integral part of your socio-cultural milieu, basically. As long as, I don't think, never, at least this is my personal take, never cultivate them. In the sense that don't offer them an extra sort of a space in your clinics.
Okay.
Both, either it could be financial or even otherwise, is that don't offer them. Once they cling on to that, then half the time you are. I'll tell you a small example. We know that most of our psychiatric disorders, we can't offer immediate cures. Once we cultivate them, their condition will be you go to this doctor, he will cure you. And this is the amount you pay to me, that he collects for himself and sends the patient, and which you are not able to deliver. And that creates a lot of friction after few visits or few times. And it is losing a sort of a goodwill for the psychiatrist. I think best thing is, if you are in the initial phase of your practice, best thing is to say a polite no if they are intruding into your space too much. Saying a polite no, that is better, because you may delay your picking up the practice by few months or a year. That is not going to really harm you in the long run. Pardon?
Similarly, Palmi chunky ice cream.
I'm not.
అనిల్ సార్ ఏమంటున్నారు?
హలో సార్, చెప్పండి సార్.
అదే మీరే ఏదో చెప్పారు అనిల్ గారు.
నేనేం చెప్పాను
సార్? నారాయణ రావు సార్,
క్వశ్చన్స్ అయితే అయిపోయినాయి.
Sir, regarding RMP's issue, district headquarters, it is more, sir. How we deal is awareness in the public is most important technique for getting patients, sir. At the same time, politeness towards RMP is very important, sir. We do not entertain in financial way, unethical way, but giving respect him is very important, and it carries a long way.
Definitely. I'm not saying that don't give them or don't. I'm telling them don't entertain them into bringing the patients. They come
Yes,
with
sir.
another patient. Give them due respect, talk to them, help them, all those things. See, for that matter, even some traditional healers bring their patients.
Yes,
దర్గాల
Yes, sir.
నుంచి ఇక్కడి నుంచి వస్తుంటారు.
sir.
We don't say don't go there, no. We tell them, we accommodate them. At the same time, actively encouraging them may not be the real thing.
Yes, sir. Sir, so you can conclude the session, I think.
Sir, respected Dr. Chandrasekhar sir, for accepting our invitation and spending valuable time for this academic program. We are thankful to you behalf of Ipstsb, and we are thankful to Crescent Formulations for sponsoring this event and providing facility for this Zoom meeting. And we are thankful to all the attendees and all the active participants for participating in this program. And we will continue similar kind of webinars in the future for the academic excellence of all young doctors and also our senior consultants. Thank you, one and all. Thank you, President sir.
Thank you, Chandrasekhar sir, Anil
Thank
Martin,
you.
and Crescent.
Thank you very much for all the
Thank you all.
things.